Ladies and gentlemen, welcome to Medsynapse, your getaway to the latest in medical advancements and medical expertise. Today, we're honored to have Dr. Neha Lalla with us, a distinguished specialist gynecologist surgeon with a wealth of experience spanning over a decade. Dr. Neha's journey has taken her from managing complex gynecological conditions such as endometriosis, fibroids, and ovarian cysts to her current role at Prime Health. Her active involvement in national and international conferences as both a faculty member and delegate underscores her commitment to advancing the field. Additionally, serving as a course coordinator for a hysteroscopy training program in India speaks volumes about her passion for education and mentorship. Dr. Neha's expertise extends beyond conventional boundaries as she remains at the forefront of technological advancements in gynecological surgery. Her meticulous approach and unwavering dedication ensures that her patients receive nothing short of the highest standard of care. Today, we have the privilege of tapping into Dr. Neha's expertise as she will share her knowledge with us on surgical principles of myomectomy. Join us as we embark on a journey through the surgical world under the guidance of Dr. Neha Lalla. Welcome, Doctor.
Thank you so much. Thank you for having me on your podcast. And I hope it is going to be an insightful session into the world of myomectomy or fibroids.
Thank you so much, Dr. Neha, for giving us your precious time on this very interesting topic.
Thank you so much.
Dr. Neha, to begin with, what are the key surgical principles that guide a successful myomectomy procedure?
So, the key principle or the key plan of any surgical surgery is to plan the procedure well. As we are aware, fibroids are nothing but they are benign neoplasms of the uterus. They compose of certain things, like they have smooth muscle cells, they are fibroblasts and extracellular matrix, and they are very heterogeneous in nature. So different fibroids will present as different, and that's how we have to plan a procedure as well. A fibroid can be at the fundus, which will present as only a mass in the abdomen, whereas a fibroid which is pressing onto the endometrial cavity will have the patient causing bleeding, or she might present with recurrent pregnancy loss. So different location of the fibroids require different treatment or different modality of treatment, and we require to plan the procedure likewise. How will we plan the procedure? First, most importantly, while planning any procedure, we need to do clinical examination. Many times I'm seeing we are forgetting to do clinical examination because we have PVS available in the OPD. We directly jump to doing a vaginal ultrasound instead of clinically examining the patient. Like PV is being lost. But it is very important when we plan any surgical procedure, because when we are doing a surgery, when we have a vaginal examination findings, we know exactly whether the uterus is enlarged, whether the uterus is mobile, is it transversely enlarged or vertically enlarged, is it fixed uterus, are we going to face any difficulties during surgery, or is it going to be easier than easy surgery. So it is very important that we do clinical examination in the OPD. Next thing, then, when a patient we see of fibroids, we have to do an ultrasound. Of course, ultrasound is done in all the gynec conditions, but why do we need to do an ultrasound? Because we need to know whether there is feasibility of doing a myomectomy, or we will not be able to carry out myomectomy and the patient needs a hysterectomy. What type of myomectomy can we do? Can it be done laparoscopically? Or is that to be tackled hysteroscopically? Or we need a combined approach where hysteroscopy and laparoscopy both are needed? Or is it such a big fibroid, or there are multiple fibroids where we have to do it by an open or an abdominal myomectomy or laparotomy? So ultrasound helps us to map the fibroids. Where is the location of the fibroids? What are the size of the fibroids? How many number of fibroids are there? It also helps us to decide what instruments will be required while planning the procedure. Where will we place the ports if we are doing a laparoscopic myomectomy? As in, if it's a small fibroid, then we can go in via the umbilical port. However, if there are the multiple fibroids, the uterus is almost reaching up to the umbilicus, then of course we have to go with a supraumbilical entry technique, and the ports will of course be higher in that case. So all this examination and ultrasound will help us to guide. And of course, in cases of myomas which are slightly different, degenerated, it will also help us to differentiate between adenomyosis and fibroid, because adenomyosis will require a different type of procedure and different type of technique while approaching the adenomyoma. So that's why we need to do an ultrasound, which will help us to plan the procedure. Planning is the most important part of executing any kind of surgery. If we plan correctly, 80 to 90% of surgery is going to be successful. Next step that comes after ultrasound is whether we need to do a MRI in the patients when we are planning the patient for procedure. Which patients actually require MRI? Do all patients require to do an MRI? No. If there is a clear-cut diagnosis of fibroid on ultrasound, there is a single fibroid, we don't need to do an MRI for all those patients. However, in cases of multiple fibroids, where we need exact location of the fibroid, exact number, so that we can counsel the patient, if there are 8 fibroids, 9 fibroids, we can counsel the patient accordingly, that how many fibroids actually can be removed in the single step procedure. Will any fibroid be left behind? Okay, so in that case, the MRI really helps us. MRI also helps us when we need to know about the degenerations, because as you can see in the image, the one which is lower, it is showing a degenerated myoma at the anterior wall. The myoma consistency is changed. So we know that it is going to be a slightly difficult surgery. While enucleating the fibroid, we may not find it as easy as the firm fibroids. So that's when the MRI will help us. Also, in cases in the first A and B, we can see that there are 2 fibroids. In the figure A, the fibroid is an intramural fibroid, but it is pressing onto the cavity. Whereas in figure B, it's an submucosal fibroid. So the plan for both these fibroids will be totally different. So the MRI in that case will help us. So this is what these are what which will help us in guiding the surgical surgeries. Like, these are the points that we have to do before surgery, which will help us to know which type of surgery we can conduct. Nowadays, we have moved on from abdominal myomectomy to most of the time, 90% carrying out the procedures by laparoscopy or by minimal invasive surgical techniques, because there is shorter hospitalization. We have a faster post-operative recovery. There is decreased incidence of post-operative pain. The patient can get back to work faster. Also, the adhesions formation is quite less. Earlier on, when I was a student, we used to always hear that abdominal myomectomy is one of the most adhesiogenic surgeries. And when we go in again the second time for any other procedures, we'll always find a lot of adhesions of the uterus with the bowel or with the wall, with the posterior wall. But nowadays, with the minimal access procedures, the adhesion formation is quite less because of the technique of the carrying out the surgeries. Earlier, the concerns after minimal access surgery were that whether the patient will get conceived or not, what will be the reproductive outcome. However, with certain papers coming in, we have proved now that laparoscopy is the gold standard for carrying out myomectomies. So we have different type of fibroids which will be tackled differently. For example, on the screen you can see a subserosal fibroid. So these can definitely be tackled laparoscopically. Whereas in pedunculated myomas, when we are planning procedures, we know that the myoma is pedunculated, so we have to just go and cut at the base, and it will require minimum suturing, and the myoma can be morcellated easily. These are some broad ligament fibroids which have technical difficulty in the sense, when the fibroid is in the broad ligament, we have the ureter which is passing very, very close by. So when imaging will help us differentiate between intramural and ligamentary fibroid, we will be ready in the mind, or we know that the ureter is close by, and we have to safeguard the ureter before while taking out or enucleating the fibroid. So that's when planning helps us in executing the surgery and with minimal complications. In cases of there are 2 images here. On the left one, there are multiple myomas which can be tackled and the myomas can be removed. Whereas on the right, you can see that it's a condition which is also known as fibroid poisoning. But the difference between the myomas or the myomectomy is very, very less, like less than 1 centimeter. and all the fibroids cannot be enucleated in this case. And it is better to do a hysterectomy than a myomectomy in this patient, because you won't be able to remove all the myomas, and the myomas will definitely recur.
Dr. Neha, moving on to our next question, how do we proceed with counseling the patients requiring myomectomy? And could you please highlight on the importance of consent?
Counseling and consent is one of the most important aspects when we talk to the patient in the OPD to avoid any medical legal issues later on. Because the patient has to have absolute trust in the doctors, and we have to show them empathy, as well as we have to counsel them regarding the nature of the problem. Myomas are a recurring condition. Almost 50% of the myomas recur within 6 years. We have to know what to tell the patient. Single fibroids, the recurrence rate is less as compared to multiple fibroids. There is data and studies which suggest that in cases of multiple fibroids, patient will land up with a hysterectomy within 6 to 7 years. And the patient has to be aware about it when choosing the procedure. So we have to tell them about the recurrence rate. In case patient is desirous of fertility, we have to inform them that the next 6 months and next 8 months after the procedure is one where they have maximum chances of conceiving. So after the first 2 months, which are required for the healing, they can try for pregnancy. Because if they delay it, if they do the myomectomy now and then they think that after 4 or 5 years they will try for pregnancy, there is always a chance that the myomas have recurred. And it is nothing to do with the surgical technique. It is everything to do with the disease itself. Yeah. Second thing that we need to tell the patient is about incomplete procedure, because in cases of multiple fibroids, when there are 12, 13 fibroids, there will also be some seedling fibroids. We can remove as many fibroids that we see. However, there might be some 1 centimeter, less than 1 centimeter fibroids, which we may not be able to remove at that time because they're so small and deep intermediate. We are making unnecessary large incisions on the uterus to remove these fibroids. But once bigger fibroids are removed, these fibroids start growing. So we have to also tell them that sometimes it may not be possible to remove all the fibroids, and they should be aware of that. Also, when we plan for a hysteroscopic myomectomy, in cases of submucous myoma, when the submucous myomas are bigger in size, which are known as complex hysteroscopic procedures, it may not be possible to remove the fibroid in one stage because there are certain risks which are associated with hysteroscopic myomectomies, which include fluid overload. So we have to sometimes stop the procedure and have to explain the patient that this will be done in 2 stages. One will be now and one will maybe be after the next menses. So they should be aware that they are going to require a 2-step procedure. Everything should be counseled before we jump on to perform the procedure or surgery for the patient. And patients have to understand that in their own language and give us consent for the same in written. So this is regarding counseling and consent here.
Thank you so much, Dr. Neha, for highlighting on counseling the patients and emphasizing the importance of consent, as this is very crucial in any healthcare setting. It not only ensures that the patients are well informed about their treatment options, but also respects their autonomy and rights. Now, moving on to our next question. What are some of the challenges or potential risks associated with myomectomy, and how do you mitigate them during surgery?
Thank you so much. Next question. We'll put them into parts. We will talk about hysteroscopic myomectomies first, and then we will move on to the laparoscopic myomectomies and what are the complications and how can we reduce them. So submucous myomas are some other fibroids which are tackled hysteroscopically. However, all submucous fibroids cannot be tackled hysteroscopically. So we'll just talk about which fibroids we can tackle hysteroscopically and what are the complications associated with the procedure. Submucous fibroids, even though small, are the ones which cause the patient extreme bleeding like menorrhagia, and these are the patients which present first. And we can differentiate these fibroids with the help of ultrasound and MRI, as we already discussed before. In cases of submucous myoma, we need to know the exact location of the fibroid. And for helping us with that, there are certain classifications that we use nowadays, which help us even to guide whether this procedure can be done in 1 step or it requires 2 steps. The Bamsticker is one of the classifications which was used earlier on, which is nowadays not used. And we use something called as the ESG and the Lasma classification. The ESG classification is based on the uh, angle between the myoma surface and the adjacent myometrium. So, for example, in type 0, the entire myoma is inside the uterine cavity or inside the endometrial cavity, which is known as type 0 submucous myomas, which can be tackled hysteroscopically. Whereas the type 1 myomas are the ones where the wall of the myoma, the angle of the wall of the myoma and the wall of the endometrium make an angle of less than 90 degrees. Whereas type 2 are the ones which are the wall and the of the myoma and of the endometrium make an angle of more than 90 degrees, and these cannot be tackled hysteroscopically because most of the myomas is intramural and only part of the myoma is in the cavity. So these are the fibroids which have to be tackled laparoscopically. If we try tackling these myomas hysteroscopically, we land up in trouble. They can only be done by some very, very experienced hysteroscopic surgeons. This is one of the newer classifications which we use in practice nowadays to actually be able to identify the myomas which we should tackle hysteroscopically and the one myomas which we should tackle laparoscopically. This is known as Lasmar scoring. It is based on the size of the myoma, the topography, as in is it in the lower part of the cavity, the middle part of the cavity, or the upper part of the cavity? What is the extension into the base? What is the penetration into the wall? And whether it's in the lateral wall or not, according to which a scoring is generated. If it is 0 to 4, it's a low complexity hysteroscopic myomectomy, which can be handled in a one-stage procedure. 5 to 6, if the score is 5 to 6, it's a high complexity hysteroscopic myomectomy. In this case, one is it should be done by somebody who is experienced with hysteroscopic myoma procedure. Secondly, we can give in GnRH so as to reduce the size of the myoma and reduce the complications associated with it. So it can be also carried as a one stage. So as in given the GnRH for 2 months, get an ultrasound, see whether the size of the myoma has reduced, and then proceed with the procedure after 2 months. Second thing which can be counseled to the patient is two-step hysteroscopic myomectomy. That is one first stage to be done now. Remove part of the myoma or partial myoma, and then go in again after 2 months after giving in 2 months of GnRH and complete the procedure. Whereas if the score is anywhere between 7 to 9, consider laparoscopy instead of hysteroscopic techniques, even for submucous myomas. So this, if we are aware of the scoring, we can automatically reduce the complications. This is a video which shows the bipolar resectoscopy, which is a technique for hysteroscopic myomas. So this is a hysteroscopic picture of a submucous myoma in which the myoma is arising from the posterolateral wall. And first, when you go in for any procedure, first evaluate the uterine cavity, evaluate where the myoma is arising from, and then only start the procedure. In this case, you can see the bipolar resectoscope. Nowadays, to reduce the risk, we have moved from monopolar to bipolar. Earlier on, we were using monopolar resection, which required glycine, which has certain complications during fluid overload. So we have moved on from glycine to normal saline, with which we use bipolar resectoscope. Using normal saline, we can prolong the procedure because the fluid deficit which is required which is allowed for normal saline is approximately 2 liters. So we stop the procedure when the fluid deficit. That means you have to always count the inflow and the outflow. Inflow is the one which is going into the patient, and outflow is what we are getting out, which we put in. We measure that. When the fluid deficit reaches more than 2 liters, you stop the procedure. Even if the procedure is not complete, as you have already counseled the patient that you may require a 2-step procedure. So these things can be done to reduce the complications. So as we talked, we have to know about the fluid absorption. You should have a deputed trained person who is aware of the procedure and how to count the fluid deficit in the OT. That will help us. The next thing is that once you start the resection, you have to be very fast. Because literally as the blood vessels open up, the absorption increases, and we can have complications if the absorption becomes high. So important rules for resection are that you keep the ideal intrauterine pressure as 100 millimeters of mercury. Stop the procedure when the fluid deficit is more than 1.7 liters, and counsel about a two-step procedure in cases of larger fibroids. Do not attempt such fibroids for hysteroscopic myomectomy. We can also reduce the complications by giving something known as vasopressin. Vasopressin is a antidiuretic hormone. It is also a vasoconstrictor. It helps to reduce the blood loss by 60 to 70%. So this is about how we reduce the complications in cases of hysteroscopic myomectomy. When we consider laparoscopic myomectomies, we have to consider about two things which will help to reduce the bleeding. One is we use vasopressin, and second thing, you can do bilateral uterine artery ligation. Vasopressin can be injected in various methods. The method which I usually use is through a spinal needle. Introduce the spinal needle through the abdominal wall and then inject diluted vasopressin. Vasopressin has a low safety profile. That means if given in higher doses, it can cause serious complications like ARS, bradycardia. So the ideal recommended dose is not more than 80 units. That means you dilute 20 units, or that is 2 ml of vasopressin in 200 ml of normal saline, and then use only 8 to 10 units, because above that is not recommended and it can cause serious complications. Whereas just using the desired dosage can help us with the blood flow or reduce the bleeding. The half-life of vasopressin is only 20 minutes. So if required more dosage, you can repeat it. Yeah. So another thing that we can do for reducing the complications is go and do a bilateral uterine artery ligation. So what do you mean by bilateral uterine artery ligation? Is that you open the lateral pelvic wall and perform the uterine artery ligation. The uterine artery ligation, when performed, will help to reduce the blood flow to the uterus. So it will convert the high pressure flow into a low pressure flow, and it will help to reduce the bleeding during the procedure. There are certain concerns that if you do a uterine artery ligation, will it affect the future fertility? It will not affect the future fertility, because we always also know that even when we do it bilateral uterine artery ligation in cases of NSCS, when there is extreme bleeding, the collaterals develop and continue the flow to the uterus in some time, and there is no effect on the future fertility. So in this video, we can see that you go in, identify the uterine artery, identify the ureters, and then you can either ligate the uterine artery with a suture, which you can remove at the end of the procedure, or you can also just coagulate the uterine arteries, which will help to reduce the blood flow to the uterus and help to decrease the bleeding during the procedure. So two ways which we can reduce one of the most common complications during myomectomies is these. The most common complication, of course, is bleeding. So we can do these procedures.
Thank you so much, Dr. Neha. It's really wonderful. So interesting. Very high yield topic. Now, moving on to our final question of the day. With advancements in technology and surgical techniques, how has the landscape of myomectomy evolved in recent years, and what benefits do these advancements offer to patients?
So moving on to this question, early on, we could only offer the patient abdominal myomectomies because those were the only things that were available. However, nowadays with advent in technology, with higher HD cameras, 3D cameras, with robotics, we can offer the patients even with multiple myomas, we can offer the patient a laparoscopic myomectomy because it's now surgeon skill dependent. Of course, the surgeon skill it has a long learning curve. But after the learning curve is achieved, we are now pushing boundaries. We can do larger myomas. We are able to perform. There have been papers there. I know personally people, we are all doing myomas which are above the umbilicus, about 18 centimeter, 20 centimeter laparoscopy, which were earlier not even thought of. If it's a large myoma, directly do an abdominal myomectomy. Multiple fibroids, do an abdominal myomectomy. But with laparoscopy, we are giving the patients a lot of advantage, as we already spoke, that the adhesions are less. This is a patient who had an abdominal myomectomy before, and you can see that the intestine is completely adherent at the site of the previous myomectomy. So we help to reduce the adhesions with laparoscopic myomectomy. We are putting in adhesion barriers nowadays, which is like interseed or surgical. These are ORCs or oxidized regenerated cellulose, which has been proven that it helps to reduce the adhesion formations and helps in the future if they require multiple surgeries. So, and also the recovery time is faster than before. The patient goes back to patient is walking in the hospital itself. The pain is much less. Earlier, patient had to take leave from work for multiple days, which all has gone down with laparoscopic techniques and technology. So the advancement is absolutely helping the patients. And as surgeons or as laparoscopic surgeons, we are all breaking the boundaries, for which we have to shorten our learning curve by practicing, which is on the endo trainer or pelvic trainer, so which we can shorten our learning curve. And if we are consistent with it, we can become better by the day and every day.
Thank you so much, Dr. Neha, for your valuable participation in this very important topic. Your expertise on surgical myomectomy and emphasis on counseling the patients while stressing the importance of consent are greatly appreciated. It's through your thorough contribution that we can enhance the patient care and uphold on ethical standards in healthcare. Thank you so much for joining us on our platform today.
Thank you so much, Dr. Nigar. I hope that we can highlight on certain points and help others learn from our podcast. Thank you.
Definitely, Dr. Neha. Looking forward to many more sessions together on our platform.
Yes, sure, definitely.
Thank you so much. And a big thank you to our audience for their engagement and participation. Your active involvement enriches our discussions and contributes to the collective learning expertise in our Medsynapse platform. Thank you so much, and until next time, goodbye.